Hey guys, welcome back to Medicine Part 3. My name is Dr. Angad Rai, and in this part we will be continuing a little bit more about respiratory system, in which we're going to talk about pneumothorax and much more diseases. Along with that, a couple of radiology slides which were not discussed earlier because of the power cut, but we will continue with our Medicine Part 3, following with which we will talk about many respiratory disorders. Alright, so let's talk with pneumothorax, guys. So we have discussed quite well with respect to pneumothorax. What are the classical features, guys, we see? When you do an auscultation, you find that there is absent air entry. Whenever you check on auscultation, basically with respect to the breath sounds, so you will have absent breath sounds. On X-ray, absent air entry, which will, how do you see that? Absent vascular marking. There will be no vascular marking in the X-ray. Along with that, you will see tracheal shift. Now, where is the tracheal shift, guys? Because of mass effect, the tracheal shift is going to be in the contralateral side. In which side, guys? It is going to be in the contralateral side. Now, guys, pneumothorax is actually two types. One is going to be your spontaneous pneumothorax and the other one is going to be tension pneumothorax. The main difference between spontaneous and tension is based on hemodynamic instability. In short, vital stable or unstable. Remember, guys, in tension pneumothorax, the vitals which are there, it is going to be unstable. They're going to be unstable. The causes can be trauma such as gunshot injury, or it can be because of a stab injury. On the other hand, we will talk about spontaneous pneumothorax. Usually these patients, the vitals are going to be stable, and at times I have seen cases like, post COPD, they are actually having no symptoms and they have a pneumothorax. Conditions like COPD, why? Because they are smokers. Smoking. Conditions like Marfan syndrome, Ehlers-Danlos syndrome, and pneumatococcus, which we have already discussed, is caused by Staphylococcus aureus, which is an MRSA strain, and the drug of choice for that MRSA strain is going to be vancomycin. Very good, everyone. What will be the management with respect to spontaneous pneumothorax, guys? The management is going to be needle aspiration. It is going to be needle aspiration, all right? But this is this management for spontaneous pneumothorax. Now let us talk about the management with respect to tension pneumothorax. Talking a bit about the pathophysiology, what happens in pneumothorax, guys, is, so basically air is going to come into the thoracic cavity, and this air will apply pressure to the lungs, due to which the lungs is going to collapse. Now, not only that, the air is going to apply pressure to the lungs in the contralateral side. That is why the tracheal deviation which you see in the case of pneumothorax is going to be contralateral. Now, not only that, guys, if you see one thing, this is your heart, all right? If you see our heart over here, because of the contralateral pressure which is coming because of the air, our superior vena cava, what does superior vena cava do, guys? The superior vena cava is responsible for carrying the blood from the upper part of the body, while the inferior vena cava carries the blood from the lower part of the body. Both of them, if you example, this is going to be your right atrium, all right? So both of them are going to drain where? It is going to drain in the right atrium. Now, because of the pressure which is applied by the air, because obviously tracheal deviation is also there, because of this mass effect, it is going to basically block the superior vena cava and the inferior vena cava. So, guys, now just imagine if your heart is there, and in this heart, if there is no blood supply, or decreased blood supply, what will be the result of the end diastolic volume? That is also going to reduce. What is going to be the stroke volume which is coming out? That is also going to reduce. Thereby, at the end, the systolic blood pressure of the patient is also going to reduce. Now, this is a type of shock. Okay, so what will happen, guys? Because of the damage to the superior vena cava or blockage in inferior vena cava, the venous return is going to reduce, due to which the systolic blood pressure is also going to reduce, thereby producing symptoms of shock. And what type of shock do you see in case of tension pneumothorax? That is going to be obstructive shock. What type of shock, guys? It is going to be obstructive shock. All right. So as we are talking about the mass effect, deviation is there. Tracheal deviation, blockage to the superior vena and the inferior vena cava. Along with that, your apex beat is also displaced. All right. So what are the tension pneumothorax features, guys? History of gunshot or stab wound injury. Patient is going to come with respiratory distress, breathlessness, cyanosis. You will have hypotension, tracheal shift to the contralateral side, and apex shift. And on the examination, if you see on X-ray, you will see absent air entry. On auscultation, you will have absent breath sounds. Along with that, you will have something which is known as subcutaneous emphysema. Subcutaneous emphysema. Guys, you need to know the difference between emphysema and empyema. Guys, empyema is because of related to pus, Emphysema is because of air. So see, decode the word subcutaneous emphysema, air below the subcutaneous tissue. Because of this, guys, you will have some crunching like sound. Okay, that is known as Hemmam sign. Now, where do you see Hemmam sign? In surgery, there is another condition, guys. Before I answer, try to think it out. It is a condition in which a patient is vomiting a lot. Patient comes with subcutaneous emphysema. Patient comes with vomiting and chest pain. Guys, what I just discussed is Meckel's triad, which is seen in Boerhaave syndrome, and Boerhaave syndrome is also known as spontaneous esophageal perforation. All right. Again, our main funda of these all rapid revision series is so that we will integrate everything and we'll have a quick revision, right? Next, guys, let's talk about the management of tension pneumothorax. We talked about spontaneous, that was needle aspiration. With respect to tension pneumothorax, guys, the first thing which you have to do is you have to do a wide bore needle decompression. Now, where do you put this needle? Guys, ideally what we're going to do is, first we're going to put it in the 5th intercostal space. But in which line? You're going to put it in the mid axillary line if you're going to put it in the 5th intercostal space. Now, if you have maybe an army officer who's wearing, the protection which he have, usually what you can do is you can also put it in the 2nd intercostal space, but this time the line is going to be mid clavicular line. Okay, make sure that you know the difference. 5th intercostal space is like mid axillary line, 2nd intercostal space is going to be mid clavicular line. Okay, but this is the first management. The definitive management is going to be ICD, intercostal drainage tube. And where do you put the intercostal drainage tube, guys? We are going to put it in the triangle of safety. Now, what are the borders of triangle of safety, guys? The base, which is made by either the 5th intercostal space or the nipple. It will be made with the help of the latissimus dorsi muscle and the pectoralis major muscle. Remember, okay, pectoralis major, latissimus dorsi, and the intercostal space. Alright, so that is your triangular safety in which you're going to put the intercostal drainage tube. And along with that, you will have a underwater seal bag. And what type of pressure does this underwater seal bag here? It releases negative pressure. So all the water, all the fluid, all the air can come out. Alright. So this is all which you guys need to know with respect to pneumothorax, which we already discussed in radiology. Let's bring a quick summary with respect to that. Classically, what you guys are going to see, you're going to see absent vascular marking. You don't see any vascular marking. You will see there is a tracheal deviation to the contralateral side. You will see there's a tracheal deviation to the contralateral side. Along with that, guys, if the patient is going to be in the supine position, if the patient is in supine position, what do you see, guys? You see the deep sulcus sign. And if you see there is ultrasound on the USG, especially in the M mode, what do you guys see, guys? In USG M mode, you see two signs. One is going to be your barcode sign, the barcode sign, also known as the stratosphere sign. And if they'll ask you which is the most specific, if they ask you the most specific sign in the ultrasound M sign, which will be, that is going to be your lung pointing sign. Okay, that is going to be the most pointing. We have already discussed about this in detail in radiology. All right. Next, guys, let's talk about tuberculosis, a very important condition in India. So let's talk about two types of tuberculosis, guys. One is going to be your primary TB, which first time the patient happened, and second time, which is also known as secondary or reactivation one. Guys, first we need to know the location. Remember, guys, primary TB. So always remember, guys, primary people are always on the superior aspect. Obviously, they are prime, they are of prime importance. But whenever to reach on that superior aspect, you should start from the base. So what I'm trying to say is primary TB location is going to be in the upper lobe. But what part of the upper lobe? It is going to be in the lower part of the upper lobe. What side, by guys? Lower part. So how I said is primary. So prime people, they are always on the top. But to reach the top, you have to start from the lowermost part. So always remember, primary TB is going to be in the lower part of the upper lobe. While on the other hand, guys, secondary TB is going to be on the apex. Now, guys, the TB bacilli, right, it can spread to various parts. One, we are discussing about the lungs. So lungs, we know it's going to be in the primary, it's going to be the lower part of the upper lobe. This TB bacilli can go to the tonsils. In that tonsils, guys, you can have tuberculosis which is related to cervical lymphadenitis. All right, and they produce an abscess. Now, what type of abscess this is, guys? This abscess is actually a cold abscess. It is a cold abscess. Okay, now this TB can go to our GIT tract. And what is the most common site, guys? The most common site is going to be your ileum, where it forms your ileocecal TB, which has strictures, which will further cause obstructions and further more complications. All right, now, guys, what this TB bacteria does is it causes damage to our bronchial artery. So if there is any damage to an artery, you know what will happen? There will be bleeding. So guys, if you get a question, what is the most common cause of massive hemoptysis? Hemoptysis is cough and bleeding. Hemesis is basically vomit with bleeding. You guys need to know that, okay? So massive hemoptysis, they will ask you the most common cause. That is going to be your tuberculosis. That is going to be your TB, which is going to cause your massive hemoptysis. The treatment of choice for this management is obviously the artery is bleeding. So what are we going to do is we are going to embolize. So what are we going to do? Bronchial artery embolization. Bronchial artery embolization. If they will ask you guys, what is the most common cause of hemoptysis, which is the most common cause of bleeding and cough, that is going to be, guys, that is going to be your viral bronchitis. That is going to be what? That is going to be viral bronchitis. Okay. Another condition can be with respect to hemoptysis. We're just covering microbiology as well over here, guys. Endemic hemoptysis. First we talked about massive, that is TB. Overall most common, that is viral. And endemic hemoptysis is caused by Paragonymous westermanni. Paragonymous westermanni. Another microorganism which is causing a cancer, that is your Clonorchis senescens, which is causing your cholangiocarcinoma. We'll talk more about this in surgery. All right. So this is something which you need to know about TB. Now guys, since we have already talked about pneumonia, pleural effusion, pneumothorax, let's bring a table in which you will have a proper understood summary about it. Okay. First thing guys, remember in pneumonia there is usually no tracheal deviation. Okay. What about the deviation guys in pleural effusion? Try to answer it before I say. In pleural effusion the deviation is going to be in the, again, mass effect is going to be so contralateral side. Pneumothorax also again same thing, the deviation is going to be in the contralateral side. All right. Next thing guys, on percussion, whenever you do percussion over here, obviously there is something pneumonia, there is like lesions over there, so that's why what is going to be there, it's going to be dull. Now in pleural effusion, what is pleural effusion guys? It is like water. So how I remember this is pleural effusion, it's like a river, and what are there in the river? There are stones. So there is stony dull sound on time of percussion. While with respect to pneumothorax guys, it is air, so that is why it is going to be hyper resonant. What is going to be there? It is going to be hyper resonant. Next thing what we need to know is air entry. Guys, in pneumonia, remember that in pneumonia the air entry is going to be normal. That is why what we see? We see air bronchogram sign. Remember in radiology we talked about it. Whenever there is any parenchymal involvement, you will have a sign which is known as air bronchogram sign. On the other hand, in pleural effusion, the air entry is going to get reduced. And pneumothorax, there is no air entry at all. Lungs is not there. Okay. Bronchial sounds. Now first we need to know what are bronchial sounds. Guys, right now whatever I am breathing, you are breathing, these are type of vesicular breath sounds. What are vesicular breath sounds is? Vesicular breath sounds is the ratio between expiration is to inspiration, and the ratio is 3:1. What they're trying to say is it is like 3 seconds of expiration and 1 second of inspiration. Try it yourself. Whenever you breathe, usually you take more time for expiration. So that is normal. That is going to be your vesicular breath sounds. In pneumonia guys, a classic feature, how do you remember that this is pneumonia, is you're going to see bronchial breath sounds. So what is bronchial breath sounds guys is, if I do the ratio of inspiration to expiration, the ratio is going to be 1:1. While on the other hand, in case of pleural effusion, it is going to be the normal vesicular breath sound, in which if I do the ratio of inspiration to expiration, the ratio is going to be 1:3. Remember, 3 seconds for expiration. All right. While obviously breath sounds are not going to be there in pneumothorax classically, which we're talking about it again and again, that is absent breath sounds. So as we all know, in management of pneumonia, you have to give your antibiotics. In pleural effusion, what are the features? Let's talk about it quickly. If you see, once you are going to have this curve. This curve is known as your Ellis curve, guys. What is this first sign of case of pleural effusion? That is blunting of the costophrenic angle. All right. So remember Ellis curve, which is there, it is more towards the lateral side. And what is the management, guys? The management is known as thoracocentesis. And where do you do thoracocentesis, guys? You do it in the 8th intercostal space, lateral to the scapular line, not medial, lateral to the scapular line. What I said, 8th intercostal space, lateral to the scapular line. All right. Next, guys, again, we have already discussed about pneumothorax. Management also is done. All right. So here is a good differentiation. Remember what I said about bronchial sound, guys. The inspiration to expiration ratio is going to be 1:1. Whereas the vesicular sounds, the normal one, inspiration to expiration ratio is going to be 1:3. All right. So this is all what you guys need to know with respect to our respiratory part. Let's talk about fat embolism syndrome. a topic ideally for ortho, but let's discuss it about here because it has some relations with respect to our respiratory topic. So guys, first of all, need to know what is the criteria for fat embolism syndrome. Guys, the criteria which is used for fat embolism syndrome is your GERD criteria, GURD, GERD criteria. So what is fat embolism syndrome? First of all, you need to know what is the history. A classic history which comes is a young child, a young male, okay, they will come with this, a young male, maybe around 25 years old, who has a history of road traffic incident. A road traffic accident which was there was polytrauma, and in this polytrauma, guys, the patient also had a fracture of the femur, a very important fracture, because of this, now what happens is, now the fracture will be there. You also know the femur sharp fracture, a huge bone, there will be some fat globules which will be released. Now guys, what this fat globules do is, this fat globules goes and activates the cytokines. Now these cytokines are the one which is causing problem in our body. Now these cytokines go to the microvascular structure of the lung, and thereby then it starts producing respiratory distress. Then what happens, guys? It starts producing respiratory distress. This microvascular structure, this cytokines then goes and further damages the brain and then causes features of coma. Now guys, whenever you talk about coma, if you want to define coma with respect to the Glasgow coma scale, it is any value which is less than 8. Any value which is less than 8. And then the cytokines also damage the platelets, due to which you will have non-blanching petechiae. You will have these are the three features which you have to remember: respiratory distress, coma-like symptoms, syncope, and also along with that you'll have petechiae that are non-blanching, especially on the trunk. Okay. Other features which are there are fat globules can be found in the urine or in the sputum. Patient can suffer from jaundice and oliguria. Now, such symptoms in which respiratory distress, coma, you can think about infection, but then when you do the TLC count, guys, you find the TLC is reduced and the ESR, which is the erythrocyte sedimentation rate, a marker for inflammation, is going to be elevated. Alright? If you do the chest x-ray, guys, if you do the chest x-ray, what you will find is, you will find a miliary picture, which is a snowstorm-like appearance. Now, let's quickly discuss where are the conditions. Okay, again, we're going to do integration. Where are the conditions you see miliary picture? Think about it. Come on. 1. TB. 2. That is miliary TB. Silicosis. 3rd. Fat embolism syndrome. You can see it also in varicella zoster pneumonia. Alright. So there are multiple conditions which you can see is that is going to be your TB, silicosis, fat embolism syndrome, varicella zoster pneumonia, and pulmonary alveolar proteinosis as well. Alright. So then you will have the snowstorm or miliary type picture. Now what is the management, guys? Now see, respiratory distress. So what are you going to do? You're going to give supplemental oxygen. Now the patient is having cerebral edema, due to which coma symptoms are there. So what are you going to do is, you're going to give a steroid to decrease the inflammation. And what is the steroid used over here? The steroid is going to use dextromethasone. Okay, you're going to use dextromethasone. Alright. And remember, guys, we're going to use now heparin. Now usually heparin is used for the anticoagulative effect. Over here, in case of fat embolism syndrome, we are using heparin as the anti-lipogenic effect, so that it breaks down and prevents the fat for further degradation and to form fat globules. Alright, so this is all about you need to know with respect to fat embolism syndrome. Next, guys, let's talk about a very important topic, that is your pulmonary thromboembolism. First of all, whenever you talk about pulmonary thromboembolism, remember the history. Maybe it will be a lady, maybe it can be a pregnant lady, maybe it is going to be an orthopedic patient who hasn't. Main thing is lack of embolization is the very, very, very important thing, is lack of embolization. That is because of which you will have a thrombus which will be released from either the sural or either the soleal vein. Now basically what you guys have to know, what is the meaning of thrombus and what is the meaning of embolus. Thrombus, guys, is a clot which is formed and it still has not moved from a location and it is still there. Embolus is nothing but a thrombus which is now freely moving in the blood vessels. Alright. So what happens in pulmonary thromboembolism? As we talked about that, first of all, from the sural or any vein. So whenever example now we are talking about, most commonly it is the calves or the pelvic side. So from what is happening, it is from the lower body. So you guys know the blood is collected from the lower body and into the heart with the help of inferior vena cava. So what is the row is, from this part it goes to the right atrium. From the right atrium it goes to the right ventricle. From the right ventricle it goes to the pulmonary trunk. And why it is going to the pulmonary trunk? So it can reach the lungs, so that the blood can get oxygenated. Correct? Now what happens, guys, is that imagining this, it goes to the right atrium, imagining it goes to the right ventricle and then the pulmonary trunk. The common site of pulmonary thromboembolism is usually at the right lung, that also in the right descending pulmonary artery. Now just imagine if you have a pipe over here and there is something which is clogging the pipe all of a sudden. So if there is an all of a sudden clog in the pipe, whenever water is going to come, guys, the water is obviously not going to go, and along with that the water is going to start creating pressure. This pressure is now going to get radiated backwards. So let us imagine that this is going to be the right side of our lungs, and over here at the right descending artery there is a emboli. This emboli is now not letting the blood to pass flow, due to which pressure in the pulmonary artery is going to increase, due to which you will have pulmonary artery hypertension. If your pulmonary artery is getting increase in pressure, this pressure gets radiated into the right ventricle. Now this right ventricle, guys, cannot hold that pressure, due to which there will be right ventricular dilatation but without hypertrophy. Why there is no hypertrophy, guys? Because it is an acute condition. Hypertrophy is after a long time. So what is going to happen is you're going to have right ventricular dilatation without hypertrophy, and because this dilatation is increasing, what is going to happen is there is going to be septal deviation towards the left ventricle side. And you notice one thing, that if it is going and applying pressure over here, the left ventricle ka volume is reducing. So if the left ventricle ka volume is reducing, guys, stroke volume also will reduce, cardiac output is obviously going to reduce, and again patient will suffer from shock. So remember, guys, when a condition is there, a condition in which because of pulmonary thromboembolism you are having right ventricular failure, guys, this is known as acute cor pulmonale. It is known as acute cor pulmonale, and this is the pathophysiology which you need to know with respect to pulmonary thromboembolism. Let us talk about it in written diagram. So as I said, this is acute cor pulmonale, which is known as acute cor pulmonale, basically means right-sided heart failure. Sudden onset of pulmonary artery hypertension due to massive. Now remember, there are two types of pulmonary embolism. One is going to be massive. If it is only mentioned massive, then only consider massive. It is just written PE, that is going to be submassive, the normal type. Sudden onset of pulmonary artery hypertension due to the massive pulmonary embolism, you will have a sudden onset of right ventricular failure. When you do the echo, you find a sign which is known as the McConnell sign. You will have septal deviation, due to which the left ventricle cavity is going to reduce its size, and then you will have systolic blood pressure is going to fall. So guys, if they will ask you, acute cor pulmonale is because of what condition? It is because of pulmonary thromboembolism. Cor pulmonale, that is right ventricular failure without the acute condition, that is because of COPD. We have already discussed this, right? Next question, guys, if they'll ask you what is the most common cause of right ventricle failure? The most common cause of right ventricle failure, guys, is your left ventricular failure. Alright, so this is all main points and the pathophysiology of pulmonary embolism. Now guys, let us talk about the difference between massive pulmonary thromboembolism and submassive pulmonary embolism. First thing first, guys, the differentiation is in massive, again vitals are going to be unstable, and submassive, it is going to be reduced, the blood pressure is going to reduce, or it's going to be normal. The important thing what you have to see over here is you have to see the ECG. In massive pulmonary embolism, you will see the features in S1, Q3, T3. What are you going to see? Changes are going to see in S1, Q3, T3. This 1, 3 and 3 are actually the lids. So what do you see in lid 1? In the S wave, you are going to see a deep S wave. In the lid 3, the Q wave is also going to be deep, and on lid 3 you will see an inverted T wave. This is a condition which is seen in massive pulmonary embolism. Okay, what are the classic X-ray features? You will see an Hampton hump. You will see Palla sign, which I told you, the common part where the thromboembolism is there. Obviously, that area is also going to get dilated. That is going to be a dilatation of the right descending pulmonary artery. Okay, if you talk about the features in submassive pulmonary embolism, the vitals are going to be stable. In ECG, guys, you are going to see sinus tachycardia. What are you going to see? You're going to see sinus tachycardia. And how do you check sinus tachycardia and all? You guys check basically between the RR interval. So you count the large boxes, number of large boxes, just divide 300 by the large boxes and you'll get the answer. If you like to make your life stressful, you can count the small boxes, and 1500 divided by the small boxes, again you'll do RR interval. It's all about your choice in life. In the X-ray, guys, in case of submassive pulmonary embolism, the answer is going to be a normal X-ray. You won't see a Palla sign, you will not see any Hampton hump, but in case of submassive pulmonary embolism, you are going to see a normal thing. Now guys, a very important thing which is going to be there, what is going to be the management? Now, the reason of differentiation is not like just vital stable, vitals unstable. The main reason why we are dividing both these of the conditions is because of the management. Guys, in case of massive pulmonary embolism, you knew this is a thrombus, there is a clot. So what are you going to do? We are going to do thrombo, breaking down the clot. So that is thrombolysis. You're going to do thrombolysis. But guys, thrombolysis is contraindicated in submassive pulmonary embolism. I'll tell you why. Just imagine it is a small clot, okay? So it is getting stuck in, with respect to obviously small clot, but with respect to the artery, it's a large amount, it's not going too deep. If you thrombolyze a submassive pulmonary thrombus, it is further going to break down into small particles, and these are further going down into the bronchus. So we do not want that. So in case of submassive pulmonary embolism, guys, we are going to give enoxaparin, and that is going to be your anticoagulant therapy. So what are you going to give? You're going to give enoxaparin. Okay, it's just nothing, a low molecular weight heparin. All right. Again, so as we discussed earlier, the history is going to be a post-operative pregnant patient or any cancer condition that is hypercoagulable state. Pregnancy is another hypercoagulable state. You find out on the day 2 you have respiratory distress. How are you going to do the screening of pulmonary embolism, guys? You're going to do it by D-dimer. While if you talk about the investigation of choice, that is going to be by CT pulmonary angiography. Okay. Now, what is the prophylaxis, guys? How do you do prophylaxis? The prophylaxis is jaldi bhai unko chalao, because that is the main thing. Embolization was the main cause of the DVT which was there, right? So that is why first is early embolization. Pneumatic compression stocking, it tries to help to decrease the inflammation, thereby decreasing the clot formation size. Most important is enoxaparin, which we just now discussed. Even if it is massive or submassive, any operation which is there, what they recommend is that you have to give enoxaparin subcutaneous pre-op day 1, just 1 day before the operation, and 3 to 5 days after the operation, we try to continue the enoxaparin. Okay, so last, if you talk about the drugs, in the drugs, submassive pulmonary embolism, we are going to give thrombolysis. The drug which you use is altiplase. In case of pulmonary embolism, if whenever as I said, if pulmonary embolism it is considered as submassive pulmonary embolism, that is going to be your enoxaparin. And for prophylaxis also, as we told, pre-op 1 day and 3 to 5 days of post-op, that is going to be again enoxaparin. All right. So that is all which you need to know with respect to pulmonary embolism. Next, guys, let us talk about air embolism. What are the causes of air embolism? Number 1 cause is going to be decompression sickness. Decompression sickness ka history kya aayega? The decompression sickness is patients a scuba diver. Usually what they are recommended is whenever you go on a deep dive, come slowly. If a scuba diver guy, he comes very fast, rapid ascent, you will have nitrogen bubble formation. What this nitrogen bubbles will do is, they will go to the coronary artery, and thereby you will have chest pain. It will go to the cerebral vasculature, and it will cause symptoms like syncope. It goes to the pulmonary vasculature, and thereby it will be causing your respiratory distress. So what is the management for decompression sicknesses? You have to do decompression chamber. Now guys, decompression chamber is not same like hyperbaric chamber. What is hyperbaric chamber, guys? In hyperbaric chamber, the management is completely different. Now hyperbaric chamber is basically oxygen therapy. You need to know, you should not give oxygen even to a normal patient too much, because you guys know oxygen is also like a drug. Too much of oxygen is also dangerous. So there are certain treatments and certain managements in which you have to give oxygen. Number 1 which you have to remember is poisoning. What poisoning, guys? You have to give it in case of carbon monoxide poisoning. You can give it in treatment of peripheral arterial disease and also gas gangrene. Why are you giving in gas gangrene? Because the organisms which are causing gas gangrenes are anaerobic. So that is why if you will give oxygen, they will obviously die. So what is the history of gas gangrene, guys? The history is going to be maybe a soldier will be there who is having a putrefied discharge, crepitations are heard. And what is the drug of choice which we already talked about? Anaerobic infections are very good. The answer is going to be clindamycin. What is it going to be? It is going to be clindamycin. Okay. Next, guys, another cause of air embolism can be jugular vein trauma. Central line insertion also can cause air embolism, and along with that you can also get also a cause can be neurosurgery. All right. So what are the causes, guys? If you talk about what are the managements, a very important thing we need to know about is what is the management with respect to your air embolism. Okay, first thing is positioning, and the positioning which is going to be there, that is going to be your left lateral decubitus position or Trendelenburg position. Trendelenburg position basically means is your head is towards in a declined position and your legs are up. Why this is done is, first of all, lateral decompression, so that example, if there is air embolism, we want to prevent it to go to the main vasculature, main in the middle part. So what we are going to do is, we are going to put the patient in the left lateral decompression so that all the air can come in the periphery. First thing, all right. So you can see over here the imaging also over here. The bubbles which are there, they are always around the right atrium to the right ventricle. They are not going into the pulmonary artery if you put the patient with respect to the Trendelenburg position. So left lateral again periphery, and right atrium to right ventricle ke around hi rahega. That is why we are putting it in the Trendelenburg position. Remember guys, the symptoms of air embolism can only be seen in when the amount of air is going to be around 100 ml of air. Okay, it is going to be a transthoracic echo which will help us to find out, and that is the investigation of choice. At the end of the day, in case of air embolism guys, we have to go to the cath lab so that we can aspirate the air bubbles. The murmur, there is in air embolism a specific murmur can be heard, and the murmur is known as guys Melville murmur. Okay, very important guys. Melville murmur is the murmur which you hear in case of air embolism. All right. So then guys, we'll talk about some important histories, and then you have to find out the diagnosis. Remember, if there is any metal fragments into the muscle, most probably the patient can suffer from gas gangrene, putrefied, drug of choice clindamycin. If you have a sudden onset of respiratory distress and you're having cyanosis. Another thing which you have to see in the question is, if the patient is smoker or marathon runner, you're going to have what condition guys? It is going to be your pneumothorax. Just now the first thing which we talked about was this only, pneumothorax will be there, and pneumothorax especially can be smokers, COPD, Marfan's, Ehlers-Danlos or pneumatococcus. All right. Fever with GERD criteria, that is going to be your fat embolism syndrome. Post-op cancer, pregnant patient, or maybe the ortho related, that is going to be pulmonary thromboembolism. Central line insertion and the patient comes with respiratory distress, you should not mark air embolism, because more commonly which is seen in practice is, if a central line insertion is placed and patient had a history of respiratory distress, most probably it could be because of pneumothorax more than air embolism. All right. So two more topics I want to discuss. One is going to be the Silhouette sign. Basically guys, whenever you see a normal x-ray, already we discussed about this in chest x-ray, that if you see the chest x-ray, the heart borders, right heart border is made by what? Right atrium. Left heart border is made by left ventricle. Both of these borders can be clearly seen and the margins are very nicely demarcated. In conditions like most probably right middle lobe or left lingular involvement, that time you will see that the borders are lost. So over here condition, you can see that patient is suffering from a middle lobe pneumonia. That is why the right border, the demarcation has been lost. Over here you can see the patient is now suffering from a lower lobe pneumonia, and there over here also you can see that the demarcation of the left border of the heart is lost. Whenever you see these borders are lost, this is known as guys Silhouette sign. Talking about cancers, whenever you see in the this is a CECT over here you can see there is spiculated margins. Patient comes with a history of smoking and hemoptysis. Hemoptysis. Whenever you see like the spiculated margins, that time you have to suspect lung cancer. Whenever you think about lung cancer, the investigation of choice is going to be CECT. All right. Gold standard obviously is going to be biopsy. And if they ask you how do you stage, the staging is good by none other than PET scan. If you get a history of patient is having an apex tumor, patient is having Horner syndrome like conditions, what is this guys? This is nothing but Pancoast tumor. And the investigation of choice of Pancoast tumor is because it is involving nerves. That is why it is going to be MRI. So over here you can see an apex type tumor over here. That is going to be your Pancoast tumor. Over here, if you see here, this is basically Mets, and there are cannonball Mets. Cannonball Mets. Now, question is, where do you see cannonball Mets? It's an obstetric condition. You see this in the cancer which is known as choriocarcinoma. Choriocarcinoma, and they will ask you another question is, what stage of choriocarcinoma, guys? Where they see metastasis to the lungs, that is going to be stage 3, not stage 4. It is going to be stage 3. Okay guys, so you will have a history of lung cancer, will be history of smoking and hemoptysis, and these are the further differentiation. Okay, So here we are done with part 3 of medicine. Always remember to read this before and after you start the questions. We're done with medicine part 3. I hope you understood. If you have any other doubts, you have my Telegram channel there. You can text me also in DM also. And I hope this was an entertaining and understanding session. Take care. Sayonara.